Hello and welcome back to class. This is Applied Anatomy and Physiology, AAP 301 for the College of Natural Health Sciences, Bermuda. My name is Dr. Delcina Bean Burrows, and this is lecture number 5. And of course, we are looking at the Archer and Nelson textbook, Applied Anatomy and Physiology for Manual Therapists. And chapter 5, we will cover the skeletal system. In terms of our lecture objectives for lecture number 5, upon completion of today's lecture, students will be able to provide several examples of how knowledge of bone and joint structures is applied in manual therapy practices, list and explain the primary functions of the skeletal system, name the primary bones of the skeleton and identify them as axial or appendicular, name the 2 types of bone tissue and describe the key features of each. Name and describe each of the 4 bone classifications according to their shape. Identify the key parts of a long bone and describe the composition and function of each. Name the key bone landmarks of the body and locate them on a diagram. Name and define the 3 structural and functional categories of joints and provide examples of each. Name the 5 common structures of all synovial joints and explain the common function of each. List the 6 types of synovial joints and provide examples for each. List and demonstrate the movement capabilities of each type of synovial joint and describe common skeletal system changes associated with aging and their implications for the practice of manual therapy. Now, in terms of the introduction for our lesson today, I'd like for you to consider the following points. Postural and movement assessments are significant for manual therapists. Bone landmarks provide important reference points for evaluation. Skeletal structures work together to support, protect, and allow freedom of movement. And recognizing structural imbalances are very important. And many times the structural imbalances is what we will address as manual therapists. Let's now consider the functions of the skeletal system. We know that the skeletal system serves as a framework for the body to give general support. It also serves in terms of protection of the internal organs. It provides a lever system and fulcrums for movement. It is also the site for mineral storage within the bones. And it is also the site for blood cell production in the bone marrow. The skeleton is divided into the axial skeleton and the appendicular skeleton. The axial skeleton consists of 8 cranial and 14 facial bones, the hyoid bone, which is in the anterior neck, the 3 ossicles, which are inside each ear, 33 vertebrae in the spinal column, and the rib cage consisting of the sternum and 12 pairs of costal bones. The appendicular skeleton consists of the pectoral girdle, which is made up of the clavicle, also referred to as the collarbone, and the scapula, also referred to as the shoulder blade, the upper extremity, which consists of the humerus, the radius, and the ulna, 8 carpals, which are the wrist bones, 5 metacarpals, and 14 phalanges, which are also referred to as the finger bones, the pelvic girdle, which consists of 2 os coxae, or the coxal or hip bones, each comprised of the ilium, the ischium, and the pubis, and the lower extremity, which consists of the femur, tibia, and fibula, patella, 7 tarsals, which are the ankle bones, 5 metatarsals, and 14 phalanges. Let's now talk about bone tissue and structure. Bones undergo cycles of self-destruction and reformation. This is referred to as remodeling. There is bone resorption, which is the breakdown of bone tissue, and deposition, which is the building up of new bone tissue. Homeostatic mechanisms to balance calcium and phosphorus also occur. And in the case of osteoporosis, this is known as brittle bone disease. Brittle bones cause too much resorption. Let's take a closer look at bone tissue. Osseous tissue is made of cells, fibers, and ground substance. There are 4 types of bone cells: osteoblasts, which build up bone; osteoclasts, which break down bone; osteocytes, which carry out nutrient waste exchange; and osteogenic cells, which are capable of mitosis. Compact bone tissue, or dense or cortical bone tissue, forms the shaft of long bones, and it is present as an outer layer of all bones. It is composed of osteons. Spongy bone tissue, or cancellous bone tissue, is found in the ends of long bones and throughout flat bones. It is composed of lattice of trabeculi. Osteocytes reside in both types of bone tissue. Now let's discuss bone classifications by shape. We have long bones, which are found in the appendicular skeleton, the femur, the tibia, the fibula, the humerus, the ulna, the radius, the metatarsals, the metacarpals, and the phalanges. We have short bones, also referred to as cuboid bones, and these are the carpals and the tarsals. We have the flat bones, which is found in the skull, the pelvic girdle, the sternum, the ribs, and the scapula. And we also have irregular bones. This is the vertebrae, some facial bones, and the patella. And here we see illustrated how bones are classified according to their shape, which could be short bones, long bones, irregular bones, or flat bones. Let's now take a closer look at the anatomy of a long bone. We have the epiphysis, which is the end of the bone, and it contains red marrow. We have the diaphysis, which is the bone shaft. The epiphyseal plate is the cartilaginous region between the epiphysis and the diaphysis, where bone growth occurs. We also have the medullary cavity, and this is the cavity in the middle of the shaft, and it contains yellow marrow. We also have the articulant or hyaline cartilage, which covers the articular surfaces. We also have the periosteum, which is the outer connective tissue covering. And we have the endosteum, which is the lining of the medullary cavity. Now, in terms of the bony landmarks, or sometimes they're just referred to as bone landmarks, these are distinct lines, grooves, bumps, and projections that make each bone unique. Landmarks serve as attachment points for muscles, or they are passageways for blood vessels and nerves. Some landmarks can be felt when palpating superficial tissue, and it is important for manual therapists to know where they are because they help us to locate internal structures. And when we do our palpation lab, we will certainly become very versed in knowing where the bony landmarks are. So now let's name the cranial bones, or the bones of the skull or the cranium. We have the frontal, the parietal, the temporal, the occipital, the sphenoid, and the ethmoid. And here in both illustrations, we see the sinuses of the skull. Sinuses are air-filled cavities within certain cranial as well as facial bones. In illustration A, we see the frontal view of the frontal sinus, the ethmoidal sinus, and the sphenoid sinus. In the lateral view, illustration B, we also see the frontal sinus, the ethmoidal sinus, and the sphenoidal sinus. Now let's identify the facial bones. We have the lacrimal, the nasal concha, the vomer, the palatine, the zygomatic, the maxilla, and the mandible. And here we have a very nice illustration of the anterior view of both the cranial and facial bones. Beginning on the left-hand side, we see the facial bones illustrated, beginning with the nasal bone, the lacrimal bone, the middle nasal concha, the zygomatic bone, the inferior nasal concha, the vomer bone, and the maxilla, as well as the mandible. And just beneath the mandible, we see the hyoid bone. And then over to the right, we see the cranial bones illustrated, beginning with the frontal, the parietal, the sphenoid, the temporal, and the ethmoid. Now let's consider the spinal column. The spinal column consists of 33 vertebrae divided into 5 regions. We have the cervical region, which has 7 vertebrae, and they are usually referred to as vertebrae C1 through to C7. We have the thoracic region, which has 12 vertebrae, and it's usually referred to as T1 to T12. The lumbar region, which has 5 vertebrae, and it's usually referred to as L1 to L5. The sacral vertebrae, this is 5 vertebrae, usually referred to as S1 through to S5. And we have the coccygeal, which is 3 to 4 vertebrae, and it's usually referred to as CO1 to CO4. Here we have an illustration of the normal curves of the spinal column. The lateral view here shows the number of vertebrae in each spinal region, cervical, thoracic, lumbar, and sacral. And it also illustrates what their natural curvature would look like. So now let's discuss spinal deviations in terms of the normal curvature of the spine. The spinal column can develop exaggerated lordotic or kyphotic curves as functional adaptations or in conjunction with diseases such as osteoporosis. A hyperlordotic curve in the lumbar spine is commonly called swayback, while the term humpback is sometimes used to describe hyperkyphosis of the thoracic region. An abnormal lateral curve is called scoliosis, and this can also develop. In many cases, scoliosis involves more than a simple S curve. There is an actual twist in the spinal column, referred to as rotoscoliosis, that increases the complexity of the condition. Any deviation from normal spine structure can be congenital or caused by long-term mechanical stress on the vertebrae due to muscular strain, imbalance, or disease. Spinal deviations decrease the overall strength, resilience, and flexibility of the spinal column and can cause nerve irritation, restricted breathing, or lead to severe dysfunction in the organs of the ventral cavities. Several forms of manual therapy have been shown to be effective ancillary modalities for reducing pain, muscle spasm, and movement limitations associated with these conditions. In some cases of severe spinal deviation, therapists may need to adjust the client's position and use supportive cushions or bolsters to stabilize and assure the client's comfort. Now let's consider the landmarks of the thorax. We have the sternum, of which we have the manubrium and the xiphoid process, and we also have the 23 pairs of costals. We have ribs 1 through 7, which are considered to be the true ribs because they connect directly to the sternum. And then we have the false ribs that do not connect directly to the sternum, but instead connect to the costal cartilage just above them. And then we have the last two of the false ribs, ribs 11 and 12. They do not connect to the cartilage above them, and therefore they are considered to be floating ribs. Now let's take a look at the landmarks of the pectoral girdle. We have the clavicle, of which we have the clavicular notch, the sternoclavicular or the SC joint, the acromioclavicular or the AC joint, and then we have the scapula, of which we have the superior and inferior angles. We have the axillary and the vertebral borders, and we have the fossae and the processes. In terms of the landmarks of the upper extremity, we have the glenohumeral joint or the shoulder joint, the humerus, the radius, and the ulna, and we also have the wrist and the hand. Now let's take a look at the landmarks of the pelvic girdle. We have the sacrum and the os coxae, which consists of the ilium, the ischium, and the pubis. We have the acetabulum. We have the obturator foramen. We have the pelvic inlet. We have the anterior and posterior superior iliac spines. We have the iliac fossa. We have the ischial tuberosity. The landmarks of the lower extremity, we have the hip joint, the femur, the tibia, the fibula, and the patella. We also have the ankle and the foot. Now, in terms of surface anatomy for us as manual therapists, we will often need to visualize the relationship of key skeletal structures and landmarks to effectively assess and treat our clients. Here we have an upper body anterior view, and what is very evident is, first of all, from the left-hand side, we can see the sternal notch. Going down further, we see the xiphoid process. We also see the iliac crest. We also see the pubic symphysis. And back up to the right-hand side at the very top, there's the sternoclavicular joint, the lateral head of the clavicle, the true ribs, and the false ribs. And as we do our practical training and our palpation skills lab, we will get more than versed in where these landmarks are in terms of the surface anatomy, but we will be able to visualize or at least be able to form a mental picture as to where these landmarks are so that we can assess our clients without actually having x-ray vision, if it were. Now, beginning from the left-hand side, the superior left, this is an upper body posterior view. We can see the spine of the scapula. We also see the acromion process. We see the iliac crest, the sacrum, and the coccyx. And of course, over to the right superior, we see the occipital ridge, the superior angle of the scapula, the inferior angle of the scapula, the posterior superior iliac spine, and the ischial tuberosity. And from the lower body anterior view, beginning from the left-hand side, most superiorly, we see the iliac crest, the anterior superior iliac spine, the pubic symphysis. We also see on the right-hand side the greater trochanter. We also see the patella, the lateral epicondyle of the femur, the head of the fibula, and the tibial tuberosity. Also, we can see the adductor tubercle and the medial epicondyle of the femur. Now, from the lower body posterior view, beginning from the left-hand side, we see the posterior superior iliac spine, and we also see the coccyx. From the right-hand side, we can see the iliac crest, the ischial tuberosity, the greater trochanter, the lesser trochanter. We also see the lateral epicondyle of the femur, the head of the fibula, the adductor tubercle, and the medial epicondyle of the femur. Let's now discuss joints. Joints, or articulations, are where two bones meet. Skeletal bones form rigid levers for movement. Joints possess fulcrums, or points where movement occurs. And joints are classified by structure or function. And here we have a joint classification chart which shows the way that joints are structured either according to their function or their structure. In terms of structural, we have fibrous, cartilaginous, and synovial joints. And in terms of functional, we have synarthrotic, which means they are immovable, amphiarthrotic, which means that they are slightly movable, and diarthrotic, which means they are freely movable. Examples of fibrous joints are the sutures of the skull, the tibiofibular articulations. Examples of cartilaginous joints are the pubic symphysis and the intervertebral joints. And examples of synovial joints are the elbow joint, the knee joint, or the hip joint. Let's briefly talk about fibrous joints. The cranial bones are held together at sutures by dense fibrous connective tissue. The proximal and distal tibiofibular articulations also allow slight shifting. Now let's look at cartilaginous joints. Fibrocartilage pad between bone surfaces allows partial movement at the joint. All cartilaginous joints are amphiarthrotic, and examples of this are the joint between the pubic bones, known as the pubic symphysis, and the intervertebral joints between the vertebrae where the intervertebral disc lie. Now let's discuss synovial joints. All synovial joints are diarthrotic and have four common structural features. They have articular or hyaline cartilage, which protects the bone's ends. They are stabilizing fibrous joint capsule. They have a synovial membrane that secretes synovial fluid. And they have stabilizing ligaments inside or outside of the joint capsule. Here we have illustrated the various types of synovial joints. Synovial joints are classified according to the shape of the bone ends, how they articulate, and the movements they allow. The hinge joint is one example of the 6 synovial joints. Like a hinge on a door, the rounded end of one bone articulates with a groove or trough in another to create this type of joint. Movement is limited to one plane, which is the sagittal plane, and the possible movements are flexion, which is bending, and extension, which is straightening. Examples of hinge joints are the jaw, the elbow, the knee, the ankle, and the interphalangeal joints. The next type of synovial joint that we will consider is the condyloid joint. These joints, which are also referred to as ellipsoid joints, are characterized by two oval-shaped articular surfaces, one convex and one concave, that fit into one another. The movement occurs in two planes, which is the sagittal and the coronal, and the possible movements that we get at these joints are flexion and extension occurring in the sagittal plane, abduction or abduction, and adduction or adduction that occur in the coronal plane. Examples of condyloid joints are the wrist, the MP joint, and the metatarsal phalangeal joints. We will now consider the pivot joints. Pivot joints are also a type of synovial joints. When a round articular surface of one bone fits into the bone ring or notch of another, it allows the bone to rotate around a single axis like a wheel on an axle. The movement that occurs in the transverse plane is rotation. And examples of pivot joints are the atlantoaxial joints, and we're specifically referring to the articulation between the atlas C1 and the axis, which is C2, and the proximal radial ulnar joint. The next type of synovial joint that we will consider is the saddle joint. Both bone surfaces in this joint are shaped like a saddle. They are orientated perpendicular to each other to create a joint that allows basically the same motions as a condyloid joint. Therefore, movement occurs in two planes, the sagittal and the coronal. The possible movements are flexion and extension, which occur in the sagittal plane, abduction or abduction, and adduction or adduction, which occur in the coronal plane. And the best example of a saddle joint is the carpometacarpal joint in each thumb. The next type of synovial joint that we will consider is the ball and socket joint. Just as the name implies, these joints are shaped like a rounded ball fitted inside a shallow bowl or a socket. Movement occurs in all planes, and these joints exhibit the greatest movement capability of all synovial joints. The possible movements are flexion and extension, which occur in the sagittal plane, abduction or abduction, and adduction or adduction, which occur in the coronal plane, and internal and external rotation, which occurs in the transverse plane. Circumduction, which is also possible in the ball and socket joints, primarily occurs within the sagittal and coronal plane. Examples, of course, are the glenohumeral joint, which is the shoulder, and the acetabulofemoral joint, which is the hip. The gliding joints are the next type of synovial joints that we will consider. The bones of these joints have smooth, flat articular surfaces called facets that slide or glide across one another. Movement can occur in any axis or plane, but the amount of movement is usually quite limited. Possible movements include complex movements and adjustments in areas such as between the tarsals in the foot, which allows it to adapt to uneven surfaces, and in between the intervertebral facets, which allows the spinal column to bend, twist, and turn in multiple directions. Examples of gliding joints are the intervertebral joints and the bones of the wrist and ankle. And here we have illustrated the basic movements of synovial joints, in particular the ball and socket joint, which is the hip joint here. The hip joint allows for movement in all planes. In illustration A, the hip is in anatomical position. In illustration B, we see flexion and extension. In illustration C, we see abduction or abduction and adduction or adduction. And in illustration D, we see circumduction. Now let's define the special movement terms. Inversion is defined as turning inward. Eversion is defined as turning outward. Dorsiflexion is defined as moving the ankle in the direction of the dorsum of the foot. Plantar flexion is defined as moving the ankle in the direction of the plantar surface of the foot. Lateral flexion is defined as bending to the side from the trunk or neck. Elevation is defined as moving upward. Depression is defined as pressing or moving downward. Protraction is defined as moving a body part forward. Retraction is defined as drawing a body part back. In terms of rotation of the scapula, upward rotation of the scapula is the glenoid fossa and the acromion rotating upward. Downward rotation of the scapula is the glenoid fossa and the acromion rotating downward. Medial or internal rotation is the rotation toward the midline. Lateral or external rotation is rotation out away from the midline. Supination is when the forearm is turned so that the palms face forward. And pronation is when you turn the forearm so that the palms face backward. Radial deviation is abduction or abduction of the wrist from anatomical position. And ulnar deviation is a deduction or adduction of the wrist from anatomical position. When we discuss joints, we must discuss the pathologies of the joints. And by far, arthritis is the most common pathology that we see in joints. Arthritis simply means inflammation of the joint. When we consider what's referred to as osteoarthritis, also referred to as degenerative joint disease or DJD, it is caused by wear and tear due to injury, normal activities, or age. It's most common in the weight-bearing joints. When we talk about rheumatoid arthritis, this is an autoimmune condition, and it is particularly evident in the hands and the feet. And then we have gout. Gout is a common form of painful inflammatory arthritis, and it usually affects one joint at a time, quite often the big toe joint. And in the course of our careers as natural health practitioners, manual therapists, we will see quite a number of our clients with arthritis, and they will be seeking our help in terms of helping them manage their pain, strengthen their muscles so that they can be in alignment, and to slow the effects of arthritic conditions. Let's now discuss aging and the skeletal system. There are some common changes that are related to aging. There is decreased density of bone tissue matrix, which results in bone loss, the wearing away of the articular cartilage. There is decreased range of motion. There is increased joint pain. There is decreased production of blood cells. And we as manual therapists should take extra precautions when performing our treatments, recognizing that the aging are very delicate, their skin is very delicate, and so the amount of pressure that we apply when we are performing our treatments must always be graded. So we've reached the end of our lecture, and for today's assignment, I'd like for you to name and explain the 5 functions of the skeletal system, list the 4 types of bones, name and define the 3 structural classifications of joints and describe the movement capability of each, and also name and explain the movement capability of the 6 types of synovial joints. And as usual, if you have any difficulty whatsoever with this assignment, please shoot me an email or send me a text message. As always, my office hours are on Thursdays from 4 to 6 p.m. And with that, do have a great week.